Good afternoon, everyone. Am I audible to all?
Yes.
On behalf of Pushpagiri Centre for Evidence-Based Practice, a JBI Centre for Excellence, it's my pleasure to extend a warm welcome to each of you. First and foremost, I would like to welcome the moderator for today's webinar, Professor Dr. Matthew Pulikan. It was actually his suggestion to organize this year's local event on critical appraisal, and his leadership as Professor and Head of Department of Critical Care, Deputy Medical Superintendent at Pushpagiri Medical College Hospital, makes him an invaluable part of the session. A very warm welcome, sir. We are also fortunate to have with us Professor Dr. Rajiv A., an eminent researcher, epidemiologist, and public health expert. Thank you, sir, for graciously accepting our invitation to speak with us today. As Dr. Indu P.S., Principal of Government Medical College Kasaragod, is expecting NMC inspection, she has kindly arranged for Dr. Biju George, Associate Professor of Community Medicine at Government Medical College Kannur, to deliver today's talk. A heartfelt welcome to you, sir. I also like to extend a warm welcome to Dr. Anupam, who will be presenting the critical appraisal of the selected article. A very warm welcome to all our esteemed participants from across the globe. Please feel free to engage and interact with the speakers after each section. Lastly, I would like to acknowledge the members of the core committee of PCBP, along with Professor Dr. Elshiba Matthew, the founder director of this center. We are grateful for your ongoing support. Thank you all for being here, and I look forward to a fruitful, engaging session. Next, we would like to introduce JBI, its model of evidence-based healthcare, and the origins and purpose of JBI Global Solution Group. JBI is an international research organization that develops and delivers unique evidence-based information, software, education, training designed to improve healthcare practice and health outcomes. To achieve this, JBI works with universities and hospitals from across the globe through the JBI collaboration. In doing so, JBI ensures that the research evidence it seeks to synthesize, transfer, and implement is culturally inclusive and relevant across the diversity of healthcare internationally. Our vision is to provide better evidence to achieve better outcomes and a better future. Our mission is to promote and support the use of evidence at the point of care globally. JBI's approach to evidence-based healthcare is unique. JBI considers evidence-based healthcare as decision-making that considers the feasibility, appropriateness, meaningfulness, and effectiveness of healthcare practices, the best available evidence, the context in which care is delivered, the individual patient, and the professional judgment and the expertise of health professionals inform this process. To support this global system, the top-tier information and resources, JBI evaluates international evidence on feasibility and relevance, meaningfulness and effectiveness of healthcare intervention, which is evidence generation, incorporates this evidence into systematic reviews, which is evidence synthesis, and distributes information in accessible formats to inform health systems, professionals, and consumers, which is evidence transfer, develops programs to implement evidence effectively, and assesses its impact on healthcare, which is evidence implementation. This approach is embodied in the JBI model of evidence-based healthcare. The inner model's inner circle symbolizes knowledge, while the inner wedges outline the steps towards evidence-based decision-making. The outer wedges represent how these components can be practically actioned, with bidirectional arrows illustrating the dynamic flow. Despite evidence-based healthcare and organizations like JBI having been in existence for more than 30 years, we know that a research to practice gap still exists across all fields of healthcare. A commonly quoted estimate is that it takes an average of 17 years for 14% of published evidence to be widely incorporated into clinical practice. This lag in uptake is due to numerous gaps in the movement of research from one stage to another, including ineffective dissemination. This is where JBI evidence implementation framework is firmly situated. Evidence-based clinical audit and feedback is a valuable approach to implementing evidence into practice. Recognizing and understanding the role of professional culture, organizational support, and leadership in this process is pivotal to its successful utilization. A JBI evidence implementation project is a clinically oriented, team-based initiative toward implementing the best available evidence into an organization's systems and processes of everyday care. The widespread impact of work of JBI worldwide is attributed to the local global partnership that ensures that activities are context-driven by individuals and groups that understand their specific healthcare environment. The JBI collaboration is the engine that drives JBI's worldwide effort to promote and support the use of best available evidence to inform decisions that are made at the point of care. JBI collaborates with more than 90 plus centers of excellence and affiliated groups in all regions of the world. Collectively, these collaborating entities are known as JBI Collaboration or JBIC. The JBIC is the largest global collaboration to integrate evidence-based healthcare within a theory-informed model that brings together academic entities with hospitals and health systems. Collaborating entities are self-governing and are initiated and are coordinated through JBI. The functions of the JBI are directed toward the knowledge needs of local clinicians and consumers, with each collaborating entity leading evidence-based initiatives in their region, country, state, or specialty. The Pushpagiri Centre for Evidence-Based Practice, a JBI Centre of Excellence, is one such collaborating entity which brings together the colleges of medical, dental, and nursing under the Pushpagiri Medical Society. The centre was officially affiliated to JBI, University of Adelaide, on March 1, 2019. It was designated as a Centre of Excellence in 2022. We are dedicated to advancing evidence-based practice and fostering excellence in healthcare education and research. Our activities include short-term trainings. We focus on building the capacity of researchers, practitioners, nurses, and students through targeted training programs. These trainings include conducting primary and secondary research, equipping participants with essential skills for evidence-based practice. We offer specialized courses in systematic review, meta-analysis, helping professionals develop expertise in synthesizing and analyzing research evidence. Our research initiatives include primary research and scholarly publications, systematic reviews and evidence synthesis, implementation research to translate evidence into practice. Before we begin today's sessions, it will be helpful to understand the origins of JBI Global Solution Rule. What is globalization? Globalization was popularized by the work of sociologist Roland Robertson, who traced his roots from a Japanese business term called dochako, which emphasizes a global outlook adapted to local conditions. Globalization stresses the idea of contemporary globalization, influencing the local level of society and localization of globality. Now, let us hear from So Jordan, Executive Director of JBI, on more about Global Solution Rule.
Hello everyone, I'm Professor Zoe Jordan and I'm the Executive Director of JBI. And I'm delighted to welcome you to the JBI Global Solution Room for 2025. Whether you're joining us here in person or tuning in from across the globe, we're glad to have you with us. This week, something remarkable is happening in cities, towns, and digital spaces across the world. Researchers, clinicians, policymakers, and students from more than 60 countries are coming together, not in one location, but in many. And we're all here for one shared purpose, to advance evidence-based healthcare together. So what exactly is JBI gLocal? Well, it's a unique event series created by JBI, a global leader in evidence-based healthcare. Every year during gLocal Week, institutions and collaborators from around the world host events to share ideas, to showcase innovations, and to explore how evidence can be translated into better decisions, better practice, and ultimately better health outcomes. gLocal is more than just an event, it's a movement. It's where the global and the local meet. That's why we call it gLocal, with a little g for global and a big local, because context matters. Now, why is context so important? Because as the JBI model of evidence-based healthcare suggests, evidence doesn't exist in a vacuum. You can have the most rigorously synthesised evidence in the world, but unless it's understood and applied in the real world, in your hospital, in your community, in your health system, it won't change lives. gLocal reminds us that local voices and global knowledge are both essential. One informs the other. Together, they drive meaningful, sustainable improvements in health. This week, you might hear from colleagues across different disciplines. You might hear about innovations in implementation. You might learn about new evidence syntheses or explore real-world challenges and solutions. Each event is unique, but they all have one thing in common. From Australia to Austria, from Cameroon to Canada, from Switzerland to Sao Paulo, we're looking to find solutions to using evidence to create a healthier world. Across all of these gLocal events, JBI collaborating entities have carefully curated a program that reflects the spirit of gLocal. You'll enjoy sessions designed specifically with your context front of mind and opportunities to connect, to question and to collaborate. And just like every other event happening under the gLocal banner this week, you will be part of a global chorus of people who care deeply about improving healthcare through evidence-based action. We encourage you to share what you learn this week, not just in the room, but online, in your workplace and in your community. Use the hashtag JBI Solution Room to connect with others and to keep the conversation going. So once again, welcome. As I said at the start, you're not just attending a local event, you're participating in a global movement. Thank you for being here. Thank you for your curiosity, and thank you for your commitment to using evidence to make healthcare better for everyone. Because that's at the heart of gLocal. It's your evidence, your context, your impact. Thank you.
Next, we will go over to Dr. Matthew Pulliken, Professor and Head of Critical Care Unit, TIMS and RC. He's a leading expert in critical care.
Good evening. So, welcome to this gLocal event. What we are trying to do today is to look at what is important for clinicians. We know for clinicians, the most important thing is to do proper medication. So, do the best for your patients. So, how would you get the best or give the best for your patients? For the last 15 to 20 years, the most important movement in critical care or in hospital, ICU, or in medicine itself has been to use evidence to give the best treatment to your patients. The problem before that was, of course, we used to follow what we used to call as eminence-based medicine, which is something you learn from your seniors, listening to your seniors, but then we found out that that can have bias and the proper treatment might not always get translated to the patients. So evidence-based medicines have changed the whole impact of medical care. And now we are in the era of evidence-based medicine. However, in many countries, especially places like India, for a practicing doctor to use there are many barriers for a practicing doctor to deliver evidence-based medicine. First of all, we do not know where to get the evidence from. Second, how to analyze this evidence. And third is from the evidence, there are so much that is coming in as evidence in journals. What do you pick and what do you give to your patients? So these are the questions that we need to address, and we have to come together. For that, the best thing is there are a couple of things that we need to address today, trying to address that problem here. One of the things what we're trying to do is how to get the best evidence. So the second one is once we get an evidence, once we get a journal, how do you analyze it properly? And the third part will be whether we can use that journal and utilize it for your patients. So these are the things that we are trying to look into today. For this, we have wonderful features today. For the first talk about how to look at evidence or how to search for evidence, I am calling on Dr. Rajiv. Dr. Rajiv is my teacher too. When I was in my internship, he was the first person who trained us or giving us the baby steps into evidence-based medicine. So he's a great expert in epidemiology, public health, and research methodology. So Dr. Rajiv, the session is yours. Thank you.
Okay. Thank you, Dr. Fulikan. Very happy to be associated with Pushpagiri Centre for Evidence-Based Practice again. And, it's a nice start that, we are collaborating at this point to bring in the concepts of evidence-based medicine as propagated and promoted by John Abrix Foundation. So I see the audience is already in, and I request the audience actually to open their chat box and be ready for some interaction, because we cannot always talk together. So but then you can always chat. I'll be sending some messages in the chat box as well, and you can try to work along with me, because we have only half an hour, so we have to rush through some of the concepts in a faster fashion. But then again, half of the audience probably already know what I'm going to talk about. I'm going to talk a little bit historically, because we are currently standing at a juncture, a watershed period, if you may want to call it, because things have come in a big way in the last 2 years, which has changed the total outlook with regard to searching for information, finding the information, making decisions and all that. And we have seen revolutionary things which is happening. So some of the concepts which I'm sharing, the classical ones, probably might be a little outdated, but then we are yet to prove that the new technology is as good or even better than the old technology. So it takes a little while before we start looking at the new technology from a new perspective. So let me try to share my screen. And this is where, oh no, okay. Show my screen. Can anybody tell, what you're seeing on the screen?
PubMed search strategy.
Okay, very good. Okay, so there's a bit of okay, so I can only see the screen. I cannot see any one of you. So pardon me for that. So let's look at PubMed search strategy from the start itself. Okay, so let's look at search. And as many of you will already know, that PubMed is actually a database with a lot of variables which contain information like journal name, the title, the abstract, the keywords, the mesh terms, and all those things are actually coded into a database which is sitting in National Library of Medicine over there in America. And then thanks to the American government at one point of time, they made it free access for all of us. Before that, it was all on CD-ROMs and specialized access points and all that. Now we have access to it, so that we got a ton of research which is available to us on a click of a button. But then PubMed is an old technology, and PubMed used to depend upon what is known as indexing by people, human indexing. So that means you take a while actually to get the indexed article, so that you can search it out and then try to find out, what is the current standard of doing things. As Dr. Pulikan was already explaining, okay, so you come across a situation, a clinical situation, wherein you have to find the evidence, which is the best evidence out there, as published by your peers, not by your eminence-based, seniors and all that. Okay, so how to find that kind of evidence and then put it to use on a real-time basis. This is a concept in which a team from McMaster University came up with something known as evidence-based medicine. It was pathbreaking at that point of time. Dr. Goyat and Dr. Sackett and their team, they brought in a series of articles. Like, for example, one article which I'm showing on the screen, I hope you can see it, how to use an article about therapy or prevention. So the link is given, so we can share it in any common group which we might be having in future. But it's an old article, and there is nothing new about it. You can see it. It was published as early as in 1993. Dr. Pulikan was mentioning that. Okay, that's when we all met each other. So it was just breaking in. Gordon Goyat, David Sackett, and all that colleagues of them, they brought in a series of articles, how to read, basically how to read an article and find out the evidence from it, and then use it to treat your own patients, which will be the second session over here. My task will be just to focus on the search part of it. So imagine, probably half of you are from critical care. Okay, so imagine a population. What is the population? It's your population, the intensive care unit. Today evening at 6:23 p.m. Indian Standard Time. Okay, at 10 Friday evening, you're standing amid a storm of beeping machines, critically ill adults, and there is that particular patient who is gasping to fill the air of their lungs, and then you have to do some intervention. What intervention are you thinking about? As we'll unfold today's program session by session, we'll find that we will be forced to make a decision. Should we go for liberal oxygen therapy for a particular patient, or should we go for a conservative oxygen therapy? So this is the question which we are going to face. And then, as you can see, I have listed it out as population, intervention, and a comparator, the conservative oxygen therapy versus liberal oxygen therapy. Okay, we are only targeting a lower SpO2 of around 90%. And then the outcome is like, it's out there actually 90 days from now. How many of them will be surviving? Which arm will have a better survival and all that? And will you be depending on a senior to tell you that? Or will you look at the latest evidence as in 2025 and then make a decision that, okay, I will go with the intervention plan as I have decided. And then that means that you have to find a randomized controlled trial, randomized clinical trial, or whatever you want to call it, and then make a decision based on the numbers which is given in that article. You have to make a decision, and the ICU is pulsing around you. You have to make a decision. So people who are familiar with PICO, well and good. People who are not very familiar with PICO, any situation, any clinical situation has got 4 or 5 or 6 aspects to it. Axis, if you want to call it. One axis is population, the critically ill adults receiving mechanical ventilation in the ICU. The intervention, what you're proposing is a lower than liberal oxygen therapy, which is targeting only a kind of a mediocre SpO2 of around 90%. And what you're looking at is, is it going to save lives? And how soon? 90 days into your intervention. 3 months from now, who are we prophetic to predict these kind of outcomes, so mortality, okay, and so many other outcomes which might come up in studies like that. And I want only a randomized clinical trial as the gold standard for my decision making. And the setting here is intensive care unit. So with that idea, I go forward. Somebody wants to try it out, you can go to PubMed with the risk of me garbling your screen. There is nothing great about it. Okay, so you can actually go and search the PubMed and find the latest RCT which is published in that area. But how do you find that article? Some of these things might be archaic actually. If somebody was courageous enough to search and then you find the latest article, I am no better than that particular person, because on this day you are actually the luckiest person out there, who can find that article which we are going to discuss in the coming sessions. For that, you don't need to be very articulate, you don't need to be very scientific and all that. Sometimes you just feel lucky, as Google says, standing on the shoulder of the giants. Today I'm feeling lucky. So there is a button, there used to be a button in Google, it said that, okay, I'm feeling lucky. Now with artificial intelligence, things have all gone completely off the way. So I can give you the cheat sheet. In fact, if you search for conservative oxygen therapy right away without any scientific thing at all, probably you will find that article which has been published very recently, which might turn out to be the gold standard. Okay, I'm not bringing in systematic reviews or meta-analysis over here. Some of you might be lucky enough to find that SRMA, which is published in 2025. But the problem there is, PubMed only will give you abstract and not the full text articles and all that. So it's again up to some of our scientific groups and all that to share that kind of evidence so that we can start implementing it from day one. So let's look at the PICOs in this particular search scenario. And the population here is I'm interested in, if you look at, the author's point of view, the keywords don't have any kind of, scientific sanctity or something. When you're submitting an article, you just put some keywords like critically ill, critical care, intensive care, ICU, mechanical ventilation, ventilated patients, ventilator. And if you put it together, you have the search string, which is combined using what is known as the Boolean operator, OR. I have put it in capital so that there is no mistake about OR being odds ratio or something else. So all these terms combined together using the Boolean operator OR will make one set of arguments which you're going to search for. But then, is that the best way to do it? On some days you might be lucky with that. On some other days you may not be very lucky with that. So we would like to focus our search much more better. How do you do that? By going to a dictionary which is maintained by PubMed called MESH terms, medical subject heading terms. So you can actually go to PubMed, again at the risk of me defocusing you. There is a short form which I'll be sharing over here, which will give you the access to the dictionary. And then using that dictionary, all this critically ill, critical care, intensive care, mechanical ventilation, etc. can be mapped to phrases. By phrases, I mean the words which are given together in a quotation group. That means that the critical and illness comes together, shoulder to shoulder. It is also kind of a near operator, as we call it. So the mesh terms which are mapping to these terms which are over there is critical illness, intensive care units, respiration, artificial, otherwise it is artificial respiration. So this is your population in the PICO, PICO or PICOs. The population is actually made by these three mesh terms, which are more focused than your own phrases or the author's phrases and all that. You know what happens when somebody submits an article, they'll put keywords. And out there in National Library of Medicine, they will be using these mesh terms, which are actually a collection of phrases and all that, which will be mapped to or connected to those articles. And that's basically what is known as indexing. And indexing basically helps you to find the articles by minimal search and without much defocusing and all that. So I'll use a set of mesh terms for population. And all this will come in brackets. If you remember your high school mathematics, board mass, when you're trying to fix up an equation and find a solution, you actually follow the board mass rule. So board mass rule, you have to put brackets in appropriate places and then do the other thing, the division followed by multiplication, followed by addition, followed by subtraction. So all this, will be bracketed together so that, it doesn't overflow into the next term which are going to come. So the P will be put in one bracket, one set of bracket, three terms, one set of brackets. And the intervention, similarly, you will be using all your phrases or you can actually go for the mesh terms themselves. You go to the mesh dictionary, find out the kind of phrases which are useful, and then you come in and then search for that. Again, a bracket will uh, uh, introduce the parenthesis around oxygen inhalation therapy or oxygen / administration and dosage. The slash tells you that it's a subheading of main term, which is oxygen. The main mesh term is oxygen, and the sub term is administration and dosage is a subheading of that mesh term. So there are two things now which can be put in two sets of brackets. And how do you combine it? I'll come to that. Now, comparator, because intervention itself is oxygen and administration and dosage, comparator doesn't have a separate mesh term attached to that. Your usual thing is like usual oxygen therapy, liberal oxygen therapy, standard oxygen therapy. Those things don't have a mesh term which can be connected other than the simple mesh term, which is oxygen inhalation therapy or oxygen bar / administration dosage, or the thing, conventional oxygen therapy. You can search as such, putting it in quotes, as a phrase, or you can go with the mesh terms initially. And when you don't get lucky, you can actually dilute your search term, further and further, so that finally you get the article which you're looking for. Outcome, as we mentioned, it's either mortality or survival rate, which can be connected to items like mortality, death, survival, 90-day mortality, all-cause mortality, whatever you want. But ultimately, the mesh terms which are connected to that is mortality and survival rate. And I need to put something like a study design probably into this. Okay, there are two ways of doing it. One way of doing it is, again, putting parenthesis and putting randomized controlled trials as topic, which is a mesh term. Clinical trials as topic, mesh term, you can put it into bracket. And what do you do now? There are four sets of, or 4 or 3 or 4 sets of brackets, your BODMAS thing. And then we combine each of these using AND term. So finally, you make all your, extensive kind of, search. This was the Ovid kind of, search terms and all that. And then you combine it and then finally make up your final search term. If I may say, this is a search query structure, which I have kind of, hit upon to find the article which I require as evidence for managing my patient. So as you can see, the first set of ORs, the P, the population or the population which we are going to act on, like the patients with critical illness or in intensive care units or with respiration artificial. Okay, they are in one set of parentheses, and then I'm going to combine it with the next PI using an AND, which is another Boolean or operator, which will combine my P with I. Again, each set being bracketed in and then combined using AND between each of those P, I, C, study design and all that. So the next set is oxygen inhalation therapy or conservative oxygen therapy. And you can see that the mesh terminologies are indicated in PubMed using square brackets and the word called MESH. And then the next set is actually conservative oxygen therapy is title or abstract, because what you got in PubMed on the right side, you can see it, there is a title and there is an abstract. So you're looking for these terms in the title and abstract, not in institutions, not in the other things or any other field in the database. So you can mention that I want conservative oxygen therapy in title or abstract, and then you combine the next set, which is actually the outcome. Like I said, comparator is not there. So I go for outcome, mortality or survival rate, and then or mortality, and then title abstract, and I put a bracket there again and combine it using. So this is the second and then next, the final AND is actually putting in the study design into the picture, the randomized control trials as topic or RCT in the title or abstract. And I am adding one more thing. I want to find the latest, means that, I have to put the publication date also into the search query, so that I want it between January of 2025 to December end, give me the thing. So overall, what I was discussing was something known as the logic grid, a grid of synonyms of population, synonyms of intervention, outcome, study design, publication date, and putting it all together using and combining all the term, and then finally searching for the whole thing at one go in PubMed box, PubMed thing I already told you. Okay, and then moving on and then finding the article. And then one more thing, what you can do is, if you can focus on this side of it, you can actually find that there are some filters available. And the filters will help you to find free full text, In fact, if you look down, you have even filters for clinical trials. You can actually have filters like article type, like I said, randomized control trial. Publication date, you can actually fix using the histogram over here. And then language, you can limit to English. You can look for only human studies. And then, of course, even you can go for only high impact journals, which used to be a logic in Sackett and Guyatt kind of, logic. They will say that, look at who is the author, where the study is coming from. Can you believe it? And then only apply your evidence into your practice. So this is, in a sense, what we do in PubMed. You can look at the review titles, you can look at the abstract, and if it fits, you can look for the full text article. You can only look at primary outcomes, or maybe you can even look for the secondary outcome. Like SpO2 improved, 90% oxygen saturation achieved. Okay, all that you can actually search just by abstract screening, or maybe you can go and find out. Many times, you get links on the side, of the side of the article itself, that full text article is available, or you can actually search for the full text article wala articles only, and then find out the evidence which you require, and then you can look at you can assess it. That's the next session going to be. You can assess the quality of the study, you can critically appraise it, and then only believe what they're telling with a pinch of salt. So finally, what we'll do is, if you are successful, we'll end up in the trial which we want, and then we'll find that, okay, this is the kind of study which I'm going to apply to my patients today, and then based on that, you will go ahead. Okay, if you're not satisfied with PubMed, like in systematic review, meta-analysis and all that, you need multiple databases. It doesn't mean that, each database only takes into account a certain set of articles. No, they are complementary. Whatever is there in PubMed could be there in Embase. Only thing is, Embase has got a payment structure, so you cannot get it free. If you're lucky to be having that access, definitely you can go for Embase. Like mesh terms, Embase has got M3 terms, and you need to find out a search strategy which looks a little different over here. You can see that the phrases are in single quotes with colon followed by TEI and AB, meaning title and abstract. So you can create, and then you can combine it using and or, which are the Boolean operators. And in fact, even publication year is mentioned over here. Or the third thing to do will be, like if you're doing an SRMA, you can look at Cochrane library, which kind of, keeps all the control trials in a central register. So you can go and do the searching. It looks more or less like your Google Scholar. And then, of course, you have Scopus. Scopus search strategy is slightly different again. It says title, abstract, and the keywords. You can search for it by combining again with Boolean operators and all that. Publication year is mentioned in a little different fashion. And another thing of fashion nowadays will be Web of Science, which kind of indexes, all those things using the TS is equal to kind of terms and all that. So you can use various kinds of search algorithms, starting with PubMed, going to Embase, Cochrane Library, Scopus, Web of Science, Google Scholar, as many databases as you can go for it. Google Scholar is pretty intuitive. You can actually go to Google Scholar and you can just put the phrases which you want in quotes, and then you can search for it. Probably you might hit the jackpot, on the first page itself. And then once you find, you can even filter it out, you can say that, okay, on the site jamanetwork.com, give me all the articles, or you can say that, okay, out of the articles which I found out, give me the ones which has got PDF and all that, and PDF links are available plenty in Google Scholar also nowadays. Google Scholar is becoming pretty fashionable, popular. Okay, so you can look at it, but there is no structure to it. It's not as structured as a PubMed search and all that. But then the question is, do we really need it? That's a different question. So you find the article of relevance, and then you can actually click on similar article, find out more articles in PubMed, or maybe cited by feature is there in Google Scholar. You can get that. You can go to clinicaltrials.gov, where the proposals will be available, with the index number and all that. You can find out, what all trials are ongoing, and you can even look for systematic reviews which will appear in either PubMed or Google Scholar or wherever it is. In fact, I got lucky. There is a 2025 systematic review by Hebati et al. In PubMed itself, which is pretty useful, because, usually we say that a systematic review of all the RCTs gives better result than the RCTs singly alone, because, various reasons. So journal specific search also, you can go to the site, if you have access to that, you can find it. And then ultimately, all said and done, what we are doing is, if you do only PubMed search, probably you get lucky around 40-45% of the time. And then you go in and then search for multiple databases, probably you will get more and more articles, but not, you can see, if you search two databases, it doesn't mean that, your efficiency will go from 40 to 80, probably 40 to 70 or something. And then with mesh terms, you can focus more, you can get better results, which are focused and to the point. And then with filters, you can make it slightly more better. With a complete strategy, probably you will hit jackpot 90-95% of the time, which is what you want. In spite of that, probably you might miss some 5% of significant articles which might be published in some other language, which may not appear in any of these indexed websites and all that. Probably you need to be quite lucky, like, a blind Google search, just a Google search. And nowadays you got artificial intelligence, which will give you real articles as well as imagined articles. That danger you have to always keep it in mind. So you can even do a blind Google search also. You might get lucky on some days, and then you can adapt it, and then you can use it, as we will be seeing in the subsequent sessions. It's almost time. If there are any immediate queries, we can talk about it. Otherwise, we'll hand over the session to the next speaker.
Thank you, Dr. Ajay. That was a wonderful session. If there are any questions, we'll take it now. All right. If there's no questions, I think we'll keep it for the end.
Good evening, everyone. I hope my screen is visible. So I'll start my presentation now. So we have a critical review of the article. First of all, I'll present the article. The article is Conservative Oxygen Therapy in Mechanically Ventilated Critically Ill Adult Patients. The UK ROCKS randomized clinical trial. It was recently published in June 12, 2025 in JAMA. So an overview of the article first. So the question the trial tried to answer was, does reducing oxygen to a peripheral SpO2 of 90% reduce the all-cause 90-day mortality? And the population that underwent the trial was 16,500 of the 97 ICUs located in the UK. The intervention, the group was divided into two, which was conservative oxygen therapy and the usual oxygen therapy. And 16,500 patients were randomized into these two groups. And one group received conservative oxygen therapy and the other received usual oxygen therapy. And the outcome was the outcome measured, primary outcome measured was mortality at 90 days. So the science setting and participants, it was a multi-center pragmatic randomized clinical trial conducted in 97 ICUs, including 16,500 mechanically ventilated patients receiving supplemental oxygen. The participants were enrolled between May 2021 and November 2024, and the follow-up was completed in February 2025. The study population was critically ill adults aged 18 years or older, enrolled within 12 hours of meeting the criteria, that is receiving invasive mechanical ventilation following an unplanned admission to the ICU, or invasive mechanical ventilation started in the ICU and received supplemental oxygen. The patients were excluded if they were randomized to UK ROCKS in the previous 90 days or on receipt of extracorporeal membrane oxygenation, or if the treating clinician considered that the intervention was either clinically indicated or contraindicated. So for this particular trial, the consent was waived. So a research without prior consent approach was used, and the subjects were allowed to opt out later after randomization if decided so. And the randomization occurred as soon as possible after confirmation of eligibility. Participants were allocated 1:1 via concealed central 24-hour telephone or web randomization system to conservative oxygen therapy or usual oxygen therapy. Randomization used permuted blocks with variable block size stratified by site and the following hierarchical diagnostic subgroups: hypoxic ischemic encephalopathy, sepsis, acute brain injury, or none of the pre-specified subgroups as defined by the treating clinician was used. And the treatment allocation was not blinded. And looking at the baseline characters of the patient of age, sex, the ethnic group or the BMI, pre-existing severe respiratory diseases, various diagnoses like sepsis, HIE or acute brain injury, between the SpO2, there was Apache, which is the clinical severity of the disease. We find that the two groups are comparable or there is no difference between the two, the baseline characteristics between the two groups. And the interventions. So, aiming to minimize the exposure to supplemental oxygen, participants in the conservative oxygen therapy received FiO2 possible to maintain the SpO2 at 90%, and sites were instructed to set monitor alarms to sound if levels fell below 88% or exceeded 92%. The upper limit alarm could be deactivated once the patient was receiving an FiO2 of 0.21. And deviations were allowed if there were major discrepancies with the arterial blood gas derived oxygen saturation, that is SaO2 and SpO2, or if high FiO2 was needed to prevent an acute life-threatening illness or a change in clinical circumstance occurred that would have precluded the eligibility to the trial. And adherence to the conservative oxygen therapy group was defined as reduction in supplemental oxygen when SpO2 was higher than 92%, or an increase in oxygen when lower than 88%. In the usual oxygen therapy group, participants received supplemental oxygen at the discretion of the treating clinician, and no minimum FiO2 was mandated and no upper SpO2 limit monitor alarm was set. Outcome measures. The primary outcome was all-cause mortality at 90 days after randomization, and the secondary outcomes measured were duration of the ICU and acute hospital stay, censored at 90 days, days alive and free from organ support, respiratory, cardiovascular or kidney support at 30 days, mortality at ICU and hospital discharge at 90 days, and 60-day and 1-year mortality. The sample size was calculated as 16,500 to provide a 90% power at p-value less than 0.05 to detect an absolute risk reduction of 2.5 percentage points to 34.5% with conservative oxygen therapy. So, this is the summary of screening and randomization. Among the 52,747 patients screened, 3,514 excluded and 49,233 met the inclusion criteria. Among that, 10,754 were excluded because exclusion criteria were met, and 21,979 were eligible, but they did not undergo randomization because of various reasons, and 16,500 were randomized. Out of that, 8,258 to conservative oxygen therapy and 8,242 to usual oxygen therapy. So, result. So, this is the graph showing the FiO2, the first FiO2 requirement of the two groups. So, the blue graph is the conservative oxygen therapy and the orange is the usual oxygen therapy. We find that there is the FiO2, mean FiO2 of the conservative oxygen therapy was 0.31, that is 31%, and that of the usual oxygen therapy was about 35%. And SpO2 values, the conservative oxygen therapy, the mean SpO2, the standard deviation was 93 compared to 95.1 of that of the usual oxygen therapy. And the cumulative oxygen exposure between the two groups also differed, that the conservative oxygen therapy received about 20 hours, whereas our usual oxygen therapy about 27. So these graphs show that there is a separation between the two groups. So the primary outcome in the conservative oxygen therapy group, 2,908 participants, that is 35.4% died, compared to 2,858, 34.9% in the usual oxygen therapy. But the p-value is big, which is not statistically significant. There were no missing data among the baseline variables. And secondary mortality outcomes at ICU discharge, 60 days and 1 year, were not significantly different by the treatment group. And the secondary outcomes from this chart, we also find that the duration of the ICU stay, the duration of acute hospital stay, days alive and free from organ support at 30 days, mortality at ICU discharge, mortality at acute hospital discharge, 60-day mortality or 1 year mortality did not differ statistically between the two groups. And the subgroup analysis of the primary outcome. From this data also, we find that there is no difference between the two groups, except that probably in sepsis or in confirmed cases of in sepsis favors a usual, can favor a usual oxygen therapy, as well as the ethnic group of Black favors a conservative oxygen therapy. So this RCT, which minimizing the oxygen exposure through conservative oxygen therapy, did not reduce all-cause mortality at 90 days compared to usual oxygen therapy. And the findings are consistent with other RCTs of similar nature. The trial design differed from the others by having a usual care comparator rather than protocolized liberal oxygen therapy. The strength of the study were: the size ensured adequate power to detect the small absolute risk reduction hypothesized to be associated with conservative oxygen therapy, and high precision of the results means that a clinically important reduction of mortality from conservative oxygen therapy is very unlikely. And the efficient design using linkage to available registries to significantly reduce its cost. They had retrieved their data from various entries in the UK, so it was cost efficient. And the sample size was very high, so it was generalizable. And the patients were also rapidly enrolled following eligibility, reducing the likelihood of inappropriate oxygen therapy prior to ICU randomization. The limitations were: it was not a blinded study. The clinicians and patients could not be blinded, so the primary outcome was unlikely to be subjected to bias due to this. Then clinicians excluded a sizable proportion of the potential participants due to the intervention being either indicated or contraindicated, which could have meant patients who may have benefited were not included. So this may reduce the generalizability of the findings. And enhanced data collection was done in a limited number of subjects to find whether there was contamination between the two groups in SpO2 or FiO2. And contamination could have occurred in other subjects who were not, from whom the data was not collected. And the use of a usual care comparator, essential because clinicians were unwilling to give potentially unnecessary oxygen therapy, could increase the risk of contamination. But no evidence of this was found because separation was sustained over the trial. And other than adjusting for the baseline SpO2 and the PaO2 FiO2 ratio, prior oxygen administration could not be accounted for, and for some patients this could have been significant. And regarding protocol adherence, episodes of non-adherence occurred in 42.1%, but these episodes accounted for a small proportion of ICU hours, and overall separation of oxygen exposure between groups were substantial. So in conclusion, in mechanically ventilated adults admitted to an ICU, minimizing oxygen exposure by targeting an SpO2 of 90% did not reduce all-cause mortality at 90 days compared with usual oxygen therapy. So now we'll go on to critical appraisal of the article. I'll be using the JBI critical appraisal checklist for the for randomized control trials for appraising this article. So the first question asked us, was true randomization used for assignment of participants to treatment groups? Yes. Then was allocation to treatment groups concealed? Yes, it was concealed. Were treatment groups similar at the baseline? It was similar. Were participants blind to treatment assignments? No, they were not blinded. And those delivering treatment blind to treatment assignment, we find that that was also not blinded. And outcome assessors, were they blind to treatment assignment? Blinding was not there. And were treatment groups treated identically other than the intervention of interest? Yes. Was follow-up complete? And if not, were differences between the groups in terms of their follow-up adequately described and analyzed? The follow-up was complete. Were participants analyzed in the groups to which they were randomized? Yes. Were outcomes measured in the same way for treatment groups? Yes. And were outcomes measured in a reliable way? Yes. Was appropriate statistical analysis used? Yes. And was the trial design appropriate, and any deviations from the standard RCT design accounted for in the conduct and analysis of the trial? The trial design was appropriate. So that is also true for this study. These are the points by which the JBA uses to critically appraise the article. Thank you.
Yes. Thank you. Thank you, Anupam, for the presentation. Now, I think we'll take some questions for now. I would like Dr. Viju George and Dr. Rajiv to be part of this, so that if there's any questions and comments on this, we can. Any questions on this? Or any comments, Dr. Viju?
Yeah. See, one of the main outcome here was mortality. The key outcome was mortality. So it doesn't, we don't have to worry much about blinding for that particular thing, because the outcome is so hard outcome. There is very little chance of an error or a bias occurring in the measurement of outcome for that matter. So blinding per se is not much of an important in this particular set of a trial, in this particular. That's one thing. Second, the question was whether it would reduce mortality. Should it have been that same question, or should they have put the question whether the mortality is similar in the two groups? I have a little bit doubt on that. Should they really have probed into whether it reduces the mortality, or should have they just stick with the question like whether the mortality would be same with both the intervention? Because then some of the analytic concepts may change. It may go in for either an equivalence or a non-inferiority kind of a trial also, instead of a superiority kind of a trial. That are my two primary observations on this.
Dr. Rajiv?
Yeah, I will talk more from the point of view, when kind of evidence what you should be looking for. In your practice, I mean, you should be able to tell the opinion much better than anybody else. So this study has come out just now. Not many people have got access to it, thanks to your workshop. We have the full text article, so we are able to go through it. But otherwise, I would have looked at an article which is around, I don't know, 2018 or something, of similar nature. And then in between, there was a systematic review also. And then recently, there is a systematic review which has come out. So given a choice, which one will you go with, Will you go with UK Rocks, or will you go with a systematic review?
Probably systematic review, because I think a systematic review will analyze multiple studies and give you a better idea about what we should do. So a meta-analysis or a critical a review would be my choice for taking the evidence to my bedside. I think that will be more.
No, without actually inviting any controversy over here, like, okay, this article was picked. Okay, if I were to do just a general search and all that, probably I'll find 10 other articles which are the same nature with 1 or 2 systematic reviews also. So is it like, okay, like I said, Sackett and Goyat used to tell the first question, what they used to tell, like, okay, who are the authors? Where is it coming from? The source, because, anybody can publish anything. Even gray literature is there, things are there. So how much can you, like Dr. Biju was talking about, okay, randomization was done or blinding was done. Okay, it's after all, it's just an English sentence. Okay, how do you really trust the source and then say that whatever they have written is true? I can believe it. I can follow it. So from that point of view also, systematic reviews will contain all kinds of articles from many places. Yeah, in fact, Dr. Denny is asking a question which is a better guideline to follow for RCTs, whether it's consort or JBI. Panelists, any opinions before I give my opinion?
Just to add a clarity there. See, consort is basically a publication guideline, not actually a critical appraisal guideline. JBI is one of the different kind of critical appraisal guideline that we generally talk. JBI is one of the very good guideline there.
So yeah.
I hope, the answer is clear. Consort is a template which you will use for writing the article itself. It's not exactly for critical appraisal. Critical appraisal is entirely a different story wherein you are cutting and dissecting and trying to find out the truths, the single truth which will tell you, whether article can be believed or not. And in fact, you go beyond it in critical appraisal as proposed by Sackett and co. You will even look at the numbers which are presented. In fact, Dr. Biju and Dr. Matthew, the question was, if you look at the subgroup analysis, you find that even though the number was less, in the African Americans, the protective nature of conservative thing was much better than any other ethnic group.
Correct.
What explained it? Like,
no, nothing to explain that. I agree. It is a random this thing. And see, the other thing is it's a subgroup analysis.
yes.
So the individual power might not be as good. So when you have a subgroup analysis, that's the problem. The power is not as good. So you can have slightly different results from what would actually be there. So if you want to do, then you might have to have another study only on Black patients and look at adequate numbers to get the correct results. So these are all suggestions only, but not real outcome. The outcome is the primary outcome only. So the rest of it is all good for making evidence or to make new studies or suggestions for new studies maybe, but I don't think we can use sub-studies as a basis for informing decisions for patients.
We are asking questions and we are answering because the participants are not asking any questions. Please understand that. Anybody's got any other better questions, you can ask. And then another thing which I saw was like, okay, we are putting most importance on the mortality because it's black and white. Anybody can see it. But then there was also a beautiful graphs about FiO2 and all that. So if we did not have the mortality data to go by, would FiO2 and all that would have painted a different picture, wherein I'll say that, okay, oh my God, on conservative therapy, the FiO2 is much lower than, a liberal kind of oxygen thing, no. Politically speaking, even in popular press, it comes that, like the patient was denied oxygen, or during COVID time, we were actually splitting oxygen tubes, using jugards like, stethoscope stems and all that, sharing oxygen between two patients and all that. Oh, you're actually harming the patient. But then with evidence, we are able to much confidently say that no, it did not matter. Whether it's 90 days or 1 year, the mortality was kind of same. Whatever help we did, we helped. But at the same time, we economized on it and probably even saved some of the, I don't know, uh, 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 unexpected side effects or whatever it is. So what is your take on it? Taking surrogate endpoints.
For surrogate endpoints.
Clinically only, no statistics, nothing, just surrogate. We're looking at the monitors and order. Okay, no, this is not good, doing good.
Difficult to again without hard endpoints like mortality, other thing. Only with surrogate endpoints to take something into your clinical practice, you have to be very, very careful. Unless there is major, two things that we do in clinical practice is there a mortality benefit? Is there a hard morbidity benefit? These are the two questions that we ask. So if there is no mortality benefit, okay, what is the clear-cut morbidity benefit by this practice that your patient is getting, and is it really, really worth it, or is it just something in the air? So many of the what we see from pharma industry is something like what they show is probably as benefit is probably not really there when you look into it. Something like, okay, this medicine is twice as effective or more powerful or something like that, which actually doesn't matter to the patient. You just have to give 2 milligrams instead of 20 milligrams of this medicine, and it's equally effective. Is first of all, the patient is concerned, it probably doesn't make a difference. But if you have other surrogate endpoints like, okay, the pain is less, if the ICU stay is less, if the ventilator days is less, or things like that are also important sometimes, and that might also point towards mortality benefit if you have a large enough study. Sometimes that suggestions might be there, which you might have to be take into account.
Are we ready with Dr. Biju's presentation? Or
yes, I think we'll.
Dr. Denny's question again, coming back to, the original question, what he meant probably was, should we go with Cochrane reviews or JBI reviews? Or the risk of bias, in Cochrane or JBI kind of, appraisal?
I think the difference, what JBI is trying to do is to localize, for us to take the evidence from the world and apply it into your ICU or into your hospital. What is exactly useful in other countries might not be useful in our setup. It might be because of the cost. It might be because of antibiotic resistance or something like that, which is not the same in our country, or societal norms even might not be the same in our country as in other countries. So
in fact, I remember our discussions, way back, like when you used to tell, okay, there is evidence in foreign countries and all that. Probably it cannot be exactly, parachuted into our situation. So JBI hits upon,
what they are trying to do is, okay, can you do it local, and how can you use that evidence and make it local guidelines so that for the best outcome for the patients. I think that's what they are trying to do, which is a wonderful initiative.
Yeah.
Definitely. Yeah.
Okay. So SRMAs have come around, to full evidence-based medicine, like, 92, 93, 94 and all that. So probably they are going to apply it rather than just publish SRMAs and all that and not use any of it. Dr. Biju, your presentation is ready?
Let me see Dr. Biju's presentation. I think we'll try to present it from here.
Okay, thank you. So let me go straight to the topic as such. Can you, yeah, next. So these are the things that I'll talk. What is basically critical appraisal and what are the things that we have to check. And we'll talk a little bit about the possible tools and the checklists that are available. And probably when you summarize, what are the 5 things you can probably look to make a final decision, and then we'll conclude. Next slide. So when you say a critical appraisal, it basically means we are looking at an article to identify the strength and weakness of that article. Now, why we assess this strength and weakness? Basically to assess the validity of that and usefulness of the research finding. Now, if you're critically appraising an article from a perspective of a reviewer for a journal, then it is for thinking whether you should accept that article for publication. Now, if you're reviewing that article, critically appraising that article as a clinician, then your perspective is, should you change your practice? I think that's become more important for a clinician. By reading the article, after going through the article, after critically appraising the article, they have to make a decision. Should we believe the article and start adopting whatever is mentioned in the article, and should we change our practice based on that thing or not? That's a basic question for a critical appraiser. Next slide. And why there is a need for all this? Because there are a lot of articles being published, and as a clinician or a practitioner, they have to make decision about which article they have to choose for informed practice changes. So for that purpose, they need to have some kind of a critical appraisal skills. Next slide. And it's an essential skill for a practitioner. And as I mentioned before, aim is not to kill an article. Aim is to identify what are the strength and weakness of article. Should we change our practice? That is a basic question that we have to address at the end of a critical appraisal of an article. And in order to address that, only we use it. Okay, next slide. And these are generally the prerequisites that we say we need to have an article. We need to have some basic understanding about the methodological aspects. That means basically design and other aspect. We should have some understanding. We should have some idea about the content knowledge. And then we need some time to read the article, and then we should know what are the different components of an article, and then only we can go and read go for the critical appraisal. Next slide. This one I will just skip. Next one. Now, regarding the methodology, if you have been trained in some basic research methodology, that basic knowledge is sufficient for a critical appraisal. From the methodology perspective, that knowledge is sufficient generally. Next slide. Second thing that we need is the content knowledge. Now, if you are presenting a article which is, let us say, for example, something like this, which is basically in an ICU setup, so you should have some kind of you should have some kind of understanding about the intervention. You should have some kind of an understanding about the different kind of measurements and other things. So a content expert, a subject expert would be a better person to do the critical appraisal. That being said, any physician, any practitioner can make that kind of a knowledge by discussing with the content expert or reading sufficient thing also. No? That also can cover this kind of a knowledge also to some extent. Next slide. And then your time. My experience is we need at least 2 to 4 hours to do a critical appraisal. First 1 hour to just read the article, skim through the article, maybe a second hour to in-depth reading, another hour for searching for other articles, other similar articles, going through prior publications, etc. And last 1 hour to to formulate our thought process, writing down them, etc. So altogether, 2 to 4 hours at least would be required to do a good critical appraisal. It may be done within one stretch of 4 hours or maybe over a few days time period also. Next slide. Now, we should have some idea about the basic structure of any article. I'm not going into detail. So you should know that there's an intrad structure and these are the headings for a primary original kind of an article. And I'll use this heading and see how in each places, what are the things we have to actually go and see. Next slide. In a title, the first thing that we check is whether it reflects the study objective or not. So we should go look at the title and then look at the objectives, which will be mentioned in the last part of your introduction part, and then see whether your objective and the title, they are actually matching, and whether the title really conveys the key variables, key outcome variables, what are the interventions and outcome, etc. Okay, next slide. And generally people say SPICE is an acronym to create a good title. So you can look back at the title and see whether the title talks about the sittings, population, intervention, comparator, endpoint, and the design. And you'll find that this particular article is talking most of these components into the titles. Okay, next slide. And then look at the introduction, which basically talks about the background, the rationale, and objectives. So you should think, what was the rationale? Is it for replication of study, avoiding biases in the previous study, or new hypothesis? Maybe with a change in the variable. With time, the variables do change. You have more a different kind of investigation coming. So the variable, the way you measure the variable may change over the time. So probably this study, there are some studies in the previous which may have certain biases associated with it, maybe smaller studies with it. So they want to avoid it and they want to have some kind of a pragmatic study which take care of the different choices of the clinicians also. Okay, next slide. And then read through the article, see whether they have clearly mentioned primary objectives. Did they talk about what were the secondary objectives if they have there, and did it conflict with primary objective or not? And then go back to the introduction and see whether it starts as a broad start and then narrow down to your research question. And is it adequately cited and referenced? You can just check that one also. Next slide. Then look at the methods. Methods is for identifying the validity and for replicability. So look at the design, whether it's appropriate. So this one was a trial, and that's one of the best thing to address a question regarding an intervention. And then how did the researchers address the non-issues associated with design? One of the problem with the traditional randomized control trial is many often the participants are selected with very stringent criteria so that it may not be generalizable. So in this particular trial, they have gone for something called as a pragmatic trial with loose inclusion criteria, which allow other co-interventions and other things, etc., so that the results can be generalized more to the public, more to the general population. But one of the problem with pragmatic trials would be they will need more larger sample size because the effect size, expected effect size would be less with the pragmatic trials. And then look at the inclusion criteria, see whether they were appropriate. Look at the settings, could it influence the result? And what are the relevant time point, follow-up time? Like for in this case, they look at the 30-day, the 90-day mortality. Now, do you think the 90-day mortality is an appropriate one, or is it a 30-day mortality is more appropriate one, or is a 60-day mortality, means a 6 months mortality is more appropriate one? That you have to actually discuss with the corresponding practitioners who work in this area and make a decision regarding that. Next. What is the planned size, sample size? Was the calculation appropriate? If there is a sampling procedure, was it appropriate? What was the key variable that was measured, outcome variable in this particular situation? So it is mortality. There is not much of error in measurements. What are the statistical techniques used, methods used, were they appropriate, etc.? That was the next few questions. The next slide. Whether an IEC approval is obtained, consent were taken, whether any ethical issues were there in the. here also the ICU patients, they may not be able to give consent independently. So there is always an ethical dilemma in it. And what they have done in this particular trial is they have included all patients. And if patients can speak, they have taken a verbal consent. And later on, when the patients were moved out of this ICU, they went back to these participants. They have taken consent, fresh consent from the participant. And if the consent was not given, they have not taken further data. That is what is mentioned in this particular article. Okay, next slide. Look at the results. Results is the evidence for the conclusion that we make. In a trial, always start by looking at the baseline characteristics, whether it is displayed or not, and see whether the baseline characteristics would be similar in the two groups in a trial or not. And then look at the objective-wise results presented in the order of the primary objective, then secondary objectives and other things. See whether the results are statistically significant. See whether they have presented the effect measures like odds ratio or the difference in proportion with the confidence interval. If it is statistically significant, is it clinically relevant or not? If it is not statistically significant, was there an adequate power to detect the effect size or not? Next slide. And whether they have looked for the confounders and controlled for the confounders, you can see that in this study, they have thought about other confounders like age, FiO2 and other things, etc. Initial PO2 and other things, etc. They saturations and other things, etc. Then they have controlled it in the regression model, etc. And then whether look at the table and see whether the tables were self-explanatory, graphs were self-explanatory and other things, etc. Next slide. And when you look at the results, especially in a trial, I mentioned you should check whether there is a baseline symmetry. You can see in the table 1, I think the symmetry is there's not much difference. Only some minor difference which is expected even if you do a randomization. And we may also look at the subgroup results, because subgroup results, even though they are exploratory in nature, they may give us some clues for future research also. So as Rajiv sir was talking, he was asking whether the African American group, they have some different results compared to the other groups. So that kind of a results act as a question, further question to the next set of research, next set of trials, etc. Next slide. Okay, can you click on the next slide? Yeah. Now, sometime, in addition to the biases and statistical error, sometimes the people who do the analysis, they make mistakes also. Generally, it is picked up by the reviewer and it will be identified. But sometimes it will be missed by the reviewers and the journals also. That can also happen, and there are a lot of occasions where that kind of a thing has happened. Now, if you look at this table, it was published in Indian Pediatrics in 2008. Authors are very eminent persons. And if you look at the table, all the percentages, the numbers were given were correct, but all the percentage calculated were all wrong. So that should not have happened. And somehow the authors missed it, the reviewers missed it, the journal editors missed it, and it get published, and then people will comment about these kind of things for the lifelong. So this kind of mistakes can happen, rare to happen, but we can see occasionally in some journals still. Okay, next slide. Look at the discussion, see how the results were obtained, whether it gel with the existing pool of knowledge, and what are the implications. So check whether the researchers correctly conclude based on the results, and are the results consistent with other studies. Think about the biological plausibility for the result. Did the researchers identify the limitations correctly or not? So we have to think what were the limitations independent of what they say mentioned in the article, and then see whether the authors also mentioned that limitations or not. Next slide. See the acknowledgement, the financial and other conflicts, whether they are acknowledged or not. Next slide. References, bibliographic details, whether they are correctly given or not, etc. Next slide. Now, Dr. Denny was asking what are the different checklists that are available. JBA has one good tool, but there are other possible tools that are available. For example, CASP is one very commonly used critical appraisal skill program tools. And there are other tools, as I have mentioned here. Next slide. This is one general tool which can be used for any designs, irrespective of the design. This can be generally used, but probably a design specific tool would be more better. Next slide. For example, CASP has its own specific tools for each individual kinds of designs. Next slide. I'll just go through the CASP guideline. Remember, these guideline will not tell you whether the article has issues with it. What these guidelines will help you is to think about certain area, help you to really look at certain areas in the article, and then you have to make a judgment about whether they have done it, they have done the study in a correct manner or not. So as such, these questions will not help you to say whether the article is good as such or not, but help you to think whether the researchers have done everything in a correct manner or not. And then you have to make a judgment based on all of these criteria together. For example, CASP has 3 sections. First section is about validity. So questions like whether it addressed a focused issue, whether it was randomized, patient-centered trial were properly accounted, whether blinded, groups similar at the start, were the groups treated equally, etc. Next slide. Second section is what were the results? Look at the results and see how large were the treatment effect, precision of the treatment effect, and then local, whether the results are applicable locally or not, applicable to local population or not, clinically important outcomes were considered or not, and whether the benefits were worth harms and the cost involved in the new interventions, etc. These were the things in the CASP guideline. Next slide. Now, the consort is a reporting guideline that can help us to see whether the authors has mentioned all the points, all the segments which they are supposed to mention, but they may not help you to critically appraise it, but they will help you to see whether the authors have mentioned all the points which they were supposed to mention depending upon the design. So you may also have to need some knowledge about these reporting guideline also if you are doing a critical appraisal also. Next slide. These guidelines, you can get it from the Equator Network. Next slide. Now, I would say after reading all these articles, etc., probably you should think, what was the need for this study? What was the need for that particular study? That's the first thing that you have to think. What were the objective? What were the rationale? That you have to make a judgment. Is there a real need for the study? Second thing that you have to think, what was the methodological rigor for this study? If the rigor was there, then methodologically everything was done very good, bias was minimized, then that is a very good kind of a study. Always think about the ethical aspects of the study. If ethically something is wrong is done, then it is not at all good. Then look at the results. What was the directional result? How precise the result? Could you explain the results in terms of a biological plausibility? These things you have to think. And the last one is applicability. Can these results, okay, let us say the study is good, the results are good, but then you have to think, okay, the results are good, but can I apply these results in my own practice? So for that, you have to think whether the participants are probably are some kind of a representative of your population also, or whether these interventions, if they applied in our population, will they give you a similar kind of a results, or will they give a different kind of a results? So you have to look at the inclusion criteria of the participants, you have to look at the interventions, and then make a judgment call about the applicability, etc. So I think next slide. Yeah, that's what I want to communicate. So critical skill is an essential skill for a practitioner, and it needs some kind of an epidemiological and domain knowledge, definitely. But there are tools which can help us to some extent to navigate through this critical appraisal. In the end, always think about what was the need for the study, whether there is a methodological rigor, whether everything was done in the right way or not. Always think about whether the study was ethically done or not. Look at the results, see whether it was statistically significant, clinically relevant, not statistically significant, then whether adequate power, sample size were the. Always think about applicability to our participants, our population, our patient population or not. Okay, I think that's all. Thank you very much. And if you have some queries, I can address it.